I'm gonna shut off this one messaging, work-related messaging app that I have
We're
open.
we're live.
Okay. Shut off this one messaging.
So hello everyone, and welcome to a new session with Rights and Responsibilities Awareness Initiative. Today we are lucky to have Ernest Johansson to talk to us about a very important and essential topic: mental health crisis services. We are all under pressure. We are all under several struggling with several issues. So it's great to have some sort of resources that available. So Ernest, thank you so much for joining us today and for letting us know about those services.
I'm very glad to be here. Thank you.
So, sir, floor is yours. And please, for our audience, if you have any comment, question, please feel free to comment through our social media platforms, and I will ask our presenter accordingly. Thank you.
So, good afternoon, everyone. My name is Ernest Johnson. I am the after-hours manager at CMHA Thames Valley. Their 24/7 crisis center located at 648 Huron. And I'm here to talk about a wide variety of crisis mental health services that we provide and answer questions about um, mental health systems and how to get help if it's needed. And I'm giving several talks. So there are some topics that I might touch upon here that I might talk about more in a subsequent talk. A little bit about me. I am originally from California. I came to Canada over 20 years ago. I've been married to a woman from Canada for 23 years. So that's kind of how I ended up here. But I've been working in mental health and social services for most of my adult life. And I've been the after hours manager for a couple of years at this point, coming up on 2.5 years, I think, since we've had the position at the crisis center. Now, I want to preface things by saying that one of the reasons, and I'll touch upon this more later, that crisis mental health services work in terms of suicidality and mental health crisis is most suicide attempts are actually a combination of reactive emotions plus opportunity. And the reason why our services work is we're able to kind of intercept people at a point of reactive suicidal feelings before kind of opportunity hits. And the more our services are out there, the more that we are effective. Now, I don't want to mislead people. There are elements of suicidality, which that doesn't, my description of reactivity plus opportunity doesn't really fit. But the vast majority of suicidal attempts are likely in this area of reactive thinking plus opportunity. So I can touch upon that later and elaborate a little bit later. However, I'd like to get started, unless there are any immediate questions, I'd like to get started about the services that we offer. So we're located at 648 Huron, and I want to be like very clear. Lots of municipalities have crisis services. We certainly operate crisis services in Elgin and Oxford and Strathroy as well. And I'm speaking mostly about London. However, a lot of communities will have analogous services. So out of our 648 Huron office and across the wider agency, we operate two crisis phone lines. One is Reach Out. We offer a 1-800 number and also a local line, chats and texts. And that is a 24/7 mental health crisis line in which when you call, text, or chat online, you will be able to speak to a mental health professional 24/7, no questions asked. In that, we also have what's called the supportive listening line, which is for less mental health crisis and more people who might be lonely or not have someone to talk to. And that is a line that they can connect to as well. Additionally, we operate a national crisis mental health hotline called 988. And simply you just dial 988 in a phone. And also you can do a web search for 988 and engage in chats. And also you can text 988. And it's the same principle, but we're one of 34 providers that provide services 4988 across the country of Canada. There's an analogous service in the US as well. And it's the same principle. It's 24/7 access to a mental health worker, no questions asked, very low barrier of entry. You just have to be able to use a phone. And again, those are two examples of services we provide that can intercept people at a place of reactive suicidal thinking. Further, we also have walk-in services at the crisis center. So anyone can attend at any point. We're open 24/7, and they can speak to a mental health professional. I will say that there are times where there's a little bit of a wait because we'll have 2 or 3 counselors on fielding the walk-in clients, and there might be 6 or 7 walk-in clients at a time. And I'll speak on this a little bit later. There's a high degree of variability in the amount of people that are walking in, and there's some macro level factors that play into that, but also there's some more day-to-day factors as well. Additionally, we have what's called the crisis response team, which is a mobile team in which 2 mental health workers will go to any location within London proper at any time, 24/7, and speak to someone who's in mental health crisis. And there's a couple portals of entry or places of access for that service. Someone can call the reach out line and say they'd like to speak to the mobile team. Also several community partners can call the mobile team, including London EMS services, in addition to London Police Services. Also, the OPP can engage with us. However, the range is London proper. So it's unusual that the OPP would do that, but it has happened. Additionally, we have what's called crisis stabilization space. It is a 72-hour mental health respite bed program, and individuals from the community can stay there for up to 72 hours for several factors, or for several reasons. We are often a point of discharge when people are receiving inpatient mental health services from the hospital in London, and the hospital can directly refer to us. Additionally, we have a special kind of sequestered place within that program that's called a sensitivity space, and that is designated specifically for people who are escaping domestic violence or intimate partner violence, people who are escaping sex trafficking, and professionals such as firemen or EMS or police or what have you that are experiencing mental health crisis due to vicarious trauma. It's a little bit more of a private space. Everyone's bed is private within the program. However, there's communal spaces within the program, and the sensitivity space is designed to be a bit more private in order to handle some more sensitive situations. In addition to the hospital, we can take direct referrals from the crisis assessment team, so downstairs, and they can refer a client there, as well as there are several programs throughout the City of London that are operated by CMHA that we can have clients referred to stabilization space from. Additionally, we have what's called Tandem, and that's not really our program so much as we offer a space for it. And that is a joint project between Craigwood, Humana, and Vanier, in which they provide crisis services and some degree of referral to wider services from the crisis center for youth. So anyone 18 and under can come and see the Tandem team, and also parents who are struggling with, the mental health or behavioral patterns of a youth can also come in and speak. Now, when Tandem has limited hours, I believe they're 8 to 10 Monday through Friday, 2 to 10 Monday through Friday, 2 p.m. to 10 p.m. But we will see a youth at any time. I don't want anyone to get the message that we wouldn't see a youth at 2 a.m. if it was needed. It's just Tandem specializes in youth. In addition to that, we have the COAST team housed in our crisis center, and COAST is called Community Outreach and Support Team, and they're a joint project between LHSC, London Police, and us. And what they do is they respond to mental health calls in the 911 queue with a mental health worker, a nurse, a mental health nurse, and a police officer. And I can speak to that a little bit. And this also applies to the crisis response team program. But when there is a mental health call, oftentimes police people would be very reactive and they'll see police as a threat. And I'm not indicating that, I'm not saying, I'm not denigrating London police in that, but I'm merely stating that they come off as an authority figure. And a lot of times when people are in a reactive mental health crisis, they don't necessarily want to see authority figures. And generally, there's better outcomes if they are able to engage with a mental health worker. And that's part of the purpose of the crisis response team. And I'm doubling back a little bit, but when the crisis response team comes on scene to see a mental health call that the police have called them to, generally they'll do an assessment for immediate safety, and then they'll send the police away. And the COAST team can go and have a mental health worker engage in order to kind of de-escalate the reactivity that a client may be experiencing, and generally have better outcomes. And simply put, at times, mental health response is antithetical to the role of police. To clarify that, what I mean is people are not necessarily going to respond well to an authority figure, and they're maybe going to feel fearful to disclose more information. Additionally to that, we also have what's called the IABS team, Information and Brief Support, and they are a program in which people can walk in and see the IABS team. They operate during business hours every day of the week. And what they do is they provide 3, 4, sometimes maybe even 5 sessions with a client to arrange a wider mental health plan, to wider, more long-term services. And that's a piece about crisis, is we are short-term, keep people safe in the moment, assess for safety in the moment, and then hand them off to the appropriate services, whatever that might be. So the short of it is, those are the services we provide at the Crisis Center. Now, unless there's any specific questions about any of those services, I can talk a little bit about how, why those services work in a little bit more in depth. Okay, so as I said at the beginning of speaking, most suicidality comes from a reactive state in which someone is experiencing suicidal feelings and has the opportunity. And one of the things I like to cite, because I'm from Northern California, is the study that was done in the 1980s about people who jumped off the Golden Gate Bridge, which bridges San Francisco to Marin County. And I always tell people that Marin County is where Steven Spielberg lives. So just to place it a little bit. And the study they interviewed individuals who attempted to jump but survived. I mean, they didn't interview the people who didn't survive for obvious reasons, but they interviewed individuals who survived the jump. And the vast majority, 99+% of the individuals interviewed, and there were several hundred people interviewed for this study, regretted the attempt. And when asked if they would attempt again under the same circumstances to a person, they said they would not. And that kind of iterates the point that when people attempt suicide, it's often tied to a momentary feeling. Now, there's this state called suicidal ideation, in which someone has a challenge, a problem, an obstacle in their life, and they don't necessarily see an immediate route around it. They don't see a mechanism in which they can navigate solving this problem in a way that's amenable to them. And what happens is there'll be this thought of, if I wasn't around anymore, this problem would go away. And while our entire biology, our entire psychology is designed for us to survive, our, human spirituality, human logic, human emotion, everything is designed to protect us and survive any given circumstance. But that feeling of, I've got this enormous problem, I'd rather be dead, is also a relatively common feeling in the human experience. And it can be as benign as, I wish I could go to sleep and just never wake up. Or it can be as significant as, okay, I need to be gone, I'm going to do it at this time, at this place, by this mechanism. And most times when people are reaching out to crisis mental health services or dialing 911 or talking to someone in their community about wanting to end their life, it is reactive ideation. Problem, lack of solution, I'd rather be dead. And so what happens is, if those combinations of problem, reactive thinking, I'd rather be dead, meet an immediate opportunity to end one's life, that's where most attempts are. And I mean, people sometimes, I've had discussions with people about suicide nets on pedestrian accessible bridges, and those do save lives, because that's a very, without going too much into that piece, that's a very relatively accessible way for someone to attempt on their life. And if you take away the accessibility of that opportunity, people are less likely to be reactive. Now, that's not to say that if someone wants to end their life, they certainly can. And so I don't want to oversimplify it. There are more intense and more complex feelings of suicidality related to chronic mental health conditions, related to chronic trauma, related to extreme instances where people don't have access to basic needs. And that's kind of a different aspect of suicidality. We can treat that as well, but that's not what I'm speaking more about: ideation and reactive situational suicidality. Now, our services work because we can capture people right at the point in which they're engaging in this reactive thinking, where that thought process of, I've got this problem, I'd rather be dead, and they start exploring how to do that, we tend to catch people right there. So in order to explain this, I need to speak a little bit on the mechanisms in your brain. The short, kind of accessible explanation is that you have your high brain that houses higher level thought, logic, problem solving, thinking about macro level existence, and longitudinal thinking. And then you have your reactive brain, sometimes referred to as your lizard brain. And in your lizard brain, and I want to be clear, there's features of your lizard brain that are very much necessary for our survival. That's, for the most part, that's where people house their fight, flight, freeze thought patterns. And, I'm sitting in a home office in my home right now. If a bear jumped through my ceiling, let's say, I would go into reactive thinking. It'd be like, how do I survive right now? And that is appropriate. So it's not to say that reactive thinking is entirely bad. However, when reactive thinking involves suicidal ideation or situational suicidal ideation, that's where we need to help the brain pause and go into more longitudinal thinking in the logical brain. And essentially, through engagement in crisis services, we're able to take people out of their reactive brain and house their thinking more in the more logical part of the brain that values long-term relationships, has longitudinal thinking, has logic, understanding of action consequence. And in doing so, we can help people work through suicidal moments in which we can come to a positive solution. To give you an idea, we have, on the two crisis phone lines, between the two of them, we take roughly 180 crisis phone calls a day. A little bit of background on that. Before COVID, I think our services were less well advertised, and there was this macro level societal distress during COVID and during lockdowns, of course. But prior to COVID, our average phone line participation in a given day was about 80 calls. And now we're 160 to 180 on any given day. And a significant percentage of those are acutely suicidal callers. And we are very successful at de-escalating people from that suicidal place. For face-to-face interactions, there's a lot of variability. We'll have between 15 and 30 a day, but there's a high degree of variability related to weather, as it's raining just a touch outside, related to, there is a large degree of variability related to when it is in the month, because when people tend to get money and have more capacity to meet their basic needs, there's less engagement. And then also when there's wider level societal stressors, or specific events globally or locally that are generally distressing, we also have more engagement. So I've kind of gone through a little bit of how crisis engagement works. And yeah, is there anything you'd like me to elaborate on?
Thank you so much, Ernest, for this. Actually, question.
Yes.
Uh, for example, we know that medical services in general would take long time in order to secure an appointment, especially when we are talking about specialists. So,
Yes.
a huge advantage that could be, you know, that the shortage of that waiting time, if I may call it, because, you know, waiting 6 months to see a specialist if I'm feeling some sort of suicidal feeling wouldn't make any sense, right?
No.
So, how about that? And also, I've got another question if you, after
Sure.
you finish your comment about that.
Yeah. So that is one of the advantages we have over a lot of other systems. And generally, sometimes generally the wait is roughly, for face to face, it's roughly half an hour. Over the phone, it's we have a very good answer rate on our phone lines, and if it's not answered, it goes to voicemail and it's called back within an hour. So the wait isn't there. And a lot of times, I would suggest to people going face to face at the crisis center or requesting the mobile team takes probably legitimately 1/10 the time that going to the emergency room at LHSC or what have you would take for mental health services. Now, in our assessment process, we evaluate people for what's called the criteria for a Form 1, which is a 72-hour mental health hold at the hospital. And if someone meets the criteria for a Form 1 and we're not able to construct some sort of safety plan that takes them out of that criteria, i.e., an individual has a suicide plan to overdose and they have access to their pills and they're going to do it as soon as they get home. If we can make a safety plan where like a loved one takes possession of their pills and they agree to follow up with a service like calling our phone line if they somehow feel something escalate, and so they agree to a plan that keeps them safe and keeps them separated from that means, then we don't have to refer them for a Form 1 at the hospital. There is a percentage of clients that do come in and they need that level of more invasive help, which is a Form 1. Form 1s are legally mandatory. Once an individual is put on a Form 1, they can't leave the hospital until they're discharged, generally by a psychiatric nurse or a doctor. And part of what our service does is it takes some pressure off the emergency room for mental health calls because not everyone necessarily needs a Form 1. It's actually a very small percentage of people. And additionally, there might be someone who might need a Form 1 who we're able to construct a safety plan and build around that doesn't have to go to the hospital in the end after engagement with us. And that's a lot of the reason why we have some of our funders is because we're able to take pressure off of other systems, the 911 queue for mental health, the emergency room, EMS, et cetera. Regarding kind of the second part of that, there are long wait periods for specialists. I mean, it's frustrating. The mental health sector in general is underserved and underfunded. If an individual has insurance or cash in which they can pay for services, certainly that speeds things up, but that's not the reality of most people's lives. And so we do operate as a way to buffer that for a lot of people. And we have a lot of clients who come in on a regular basis because they're waiting for life services and we're helping them get there.
Thank you.
So does that answer the question?
Well, oh yeah, by all means. And also,
Oh,
there is another one actually.
yes.
Is there any specific requirements to use your services? For example, if somebody just came to the reception, will you ask them for example, to have an OHIP insurance or to be a permanent resident, or is there any, or is it open for everyone, anyone?
That's a good question. And actually, I should have presented that before. I get that a lot. It is open to everyone. We have private sector and public sector funders, and our mandate is to provide services for all. So you don't have to be a citizen. You don't have to have a health card. Basically, you have to show up. You have to give your name and date of birth and Do I know that some people give aliases? Yes, that does happen. And I don't judge. We don't judge. It's not our role to judge. And so you show up, receive services. We make the appropriate referrals. If the referrals to like the IABS team, for instance, will help people navigate systems a little bit. And yeah, so there's no requirement. Uh, Basically, very few people get excluded. And when people do, sometimes it's a safety issue. But that is very few and far between. In my role as manager, after hours, a lot of what I'm responsible for is safety. And it's less than 1% of 1% of situations where there's an exclusion because of safety. So just show up, no judgment, very minimal questions asked, just name, date of birth, what's going on, and then we have a session and go from there.
Well, actually, we've got here a comment on Facebook telling that, well, helpful the phone services, and I'm so thankful for the day I was welcomed and heard and no judgment. So
Awesome.
you've got your impact, Ernest, and those services are well needed, taking into consideration the pressure we are getting into our life. So yeah, thank you so much for the individual who made that comment, actually.
And
I'm
thank
pretty
you.
sure this would be highly appreciated. Another question, my friend.
Yes.
So what about privacy? When you will exclude, when you will give my information or the information I provided, my records, my sessions, my whatsoever, to a different or another party?
So that's a very good question. And a lot of people actually ask about that. So we're governed under PHIPAA, which governs all health care providers in Canada. And long story short, there are very few circumstances in which information about a client or receiver of service is disclosed without the consent of the client. And this is discussed at the beginning of any interaction. It's on the outgoing phone message of the phone lines, and it's discussed in any face-to-face interaction as kind of a preamble to the interaction. The criteria for disclosing information without the consent of the individual is very simple. One, the individual is at a risk to harm themselves acutely and potentially fatally, i.e., if someone calls us and says, hey, I'm at a bridge, I'm about to jump, in that moment, safety trumps privacy, so we call 911 and inform police and work with police to keep that individual safe. Criteria two, if someone says, I am going to kill someone, here's how I'm going to do it, this is where they are, same principle, safety trumps privacy. We call 911 and we disclose all the information we have pertinent to keeping everyone safe. There is a third criteria that's seldom used. It's about capacity to care for oneself. If someone lacks let's say the mobile team's on a visit and they go to a home and the individual very apparently can't provide for their basic needs, food, sanitary needs, what have you, then we are allowed, if the criteria is met that there's a threat to their well-being and their life potentially, we are allowed to break their privacy and inform the appropriate services. Beyond that, there's also criteria around if we have, under the Child and Family Services Act, there's provincial legislation, any healthcare professional, if they have in their good faith clinical judgment a belief that a child is going to be harmed or neglected, they also have to call either the police or the appropriate CAS. So for instance, if we have an 18-year-old come in and they say their 12-year-old younger sibling is being beaten and the abuser is still in the situation, we have an obligation to call the appropriate authorities for that. So those are the basic criteria for disclosing information without consent. Now, there's other criteria called the circle of care. So I'm a supervisor. I have 48 direct reports. And if one of my direct reports is talking to a client and wants my feedback about what the appropriate response would be to a client situation, I am considered what's part of the circle of care. I am involved in providing care for that individual that came in. So the staff member who's seeing the client can ask me, hey, what do you think about this modality and related to this line of thinking? Do you think that'd be effective? And we have a dialogue about the client's well-being. That is provided for under PHIPAA. I'm in the circle of care. I'm allowed to have that information in order to help my staff render the best services possible. Additionally, as a supervisor, I often look at my staff members' work and I read the notes and I do quality audits and all that kind of stuff. I look at statistics, and under PHEPA, I'm allowed to do that. Now, there is very specific criteria, a lot of which I already mentioned regarding how I can disseminate that information. I can't just go tell my neighbor about something or anything like that. I'm governed under that. And um, the penalties for breaking that are consequences related to one's college registration or up to legal consequences. And actually, there's a very famous case that occurred in Huron County in which a social work student looked up something like 50,000 files or some ridiculous number in a way that was wildly inappropriate, and then would discuss that information. And they were actually fined $50,000 and stripped of their college registration, and they can't work in social services in Ontario again. So there are significant penalties for that.
There's a strict rules to govern that.
Yes.
So,
Now, one other piece around that, legally under PHEPA, any individual client can request copies of all documentation related to their file. The process is basically you come in, fill out a form, and we as holders of that information have 30 calendar days to disclose it to you. One exclusionary criteria, if we can make a clinical argument that information would be harmful to the individual requesting it, we can opt not to disclose it. In my professional experience, I don't know of that happening directly. I can think of a few hypotheticals in which that would happen, but that's pretty rare. So yeah, that's it about privacy, and that's a good set of questions.
thank you. And actually, last but not least, I know you have mentioned this before, but just finally, to confirm, do I have to pay any sort of fees, admissions, some sort of anything, in exchange for the services I'm provided to?
No, you don't. You just have to show up. I mean, that's the thing. So I do lots of talks in my role. And one of the questions that I get is, what can we do to help mental health in London, in Ontario, in Canada, in the world? And my answer is always invariably, people need food, clothes, and shelter. There needs to be lower barriers for people to get their basic needs met. People need food, clothes, and shelter. And then beyond that, they need community, love, and purpose. And doing things that facilitate those basic needs and those higher level needs, that is the best thing to foster improving mental health and taking care of the wider community of mental health. And for us to charge a fee, we're a nonprofit. We don't charge a fee because we don't want to add barriers to everyone. And we don't want to add barriers to anyone. We want people to get the service. So no, there is no fee. All you do is show up. We might offer you a tea or a water. You fill out the form. You engage in the session. Worst case scenario, there's a bit of a wait, but otherwise, and it's shorter than the emergency room's wait by multiples. And we do our best to help.
Thank you so much. Well, I'm gonna take a look to our social media platforms just to see if there is any other questions, comments. So please, if you have any, feel free to use the comment. So, and then I'll ask Ernest. Well, seeing none. So, at the end of this fruitful presentation about those services and the noble work actually done by your team, Ernest, I would like to express my serious thanks to you for your time and for your team for their services and for being existed there for us. Thank you so much. And I would like just to mention that this is the first session of another 4 sessions.
Four
about
total, right?
Yeah, the 4 in total, yes. And so you will see Ernest with us in another session. They are all advertised on our website and our social media platforms. So thank you so much, Ernest, for this.
You're very welcome. And I do appreciate hearing that because sometimes we're in a position where we kind of only hear things when things go wrong. It's kind of like being a soccer referee or what have you, where you don't notice them until something goes wrong. And I'm very glad to hear some positive pieces. And one of the things that I value about what we do is, I mean, I believe very strongly in our mission statements about providing services, mental health services for all in times of crisis. I 100% believe that. I think that everyone is worthy of help when they need it. There's no questions asked about that. And I also really value our staff because I feel like there's a commonality of people with very empathetic worldviews that reject narratives that are marginalizing of people, that reject narratives that justify mistreatment of people. And I really value that our staff have that value set and that worldview that basically offers help to everyone who walks in the door. And I mean, I really try and have us embody that and do that. And so I appreciate when it's well received because we don't always hear that.
Of course, my friend, and I personally actually appreciate all of this kind effort and support we've got. So at the end of this session, I would like to thank you again, Ernest, for this time, and for everyone. Stay well, stay safe, and we are looking forward to see you at another session with Rights and Responsibilities Awareness Initiative. Thank you.
Okay. Thank you very much.